everybody, welcome. We're broadcasting live from UW Valley Medical Center in the operating room. I'm Dr. Heather Wheeler. I'm one of the general surgeons here.
I'm Dr. Greta Bernier. I'm one of the colon and rectal surgeons here.
We're here today to talk about hernias and also robotic surgery and how the two go together. I want to let you know, though, that this is totally unscripted, live, unrehearsed, so travel with us on this. So what should we talk about first? What a hernia is? Maybe?
So yeah, I think the most important things that I think of, because I'm not a hernia surgeon, is what is a hernia? Why is it important? Start there.
Okay. Well, what a hernia is a hole or a weakness in the abdominal wall. So that's the front side or the side of your belly wall or in the groin. So the hole itself is actually in the muscle layer. So when you think about the muscle layer of the belly wall, that's like your obliques and your six-pack. You all have a six-pack, even if it's hidden under a layer of other stuff. And you can get a hole in that layer, and that can cause a lot of different symptoms and problems.
Like what? What kind of symptoms or problems could people have, or what should they look out for?
Well, some people come in to me and they have a bulge or a lump in their belly or their groin, and that's the first thing they notice. Sometimes people have pain with that. So mostly those are the symptoms, and the most common places they happen are at the belly button or in the groin. Those are natural areas of weakness in the body that can happen to anyone, old, young, male, female. And then some people can have a hernia at an incision, like a prior surgical site. So those are kind of the areas that we mostly look at for hernias.
Okay. And you're obviously a hernia surgeon, and I'm sure all of us know someone who's had some kind of hernia fixed. So why do we fix them?
Well, so some people have hernias that don't need to be fixed. If you have a small belly button or groin hernia that's not causing you any problems and you've had it forever, you might not need to have that fixed. But when they get bigger, that can be a problem, or when they start causing pain or other symptoms, people will go in. Some people actually can't work with them because they're someone who does heavy labor or a lot of activity and it really bothers them, or it bothers them when they're going to the gym or something like that. Very rarely are hernias dangerous. Lots of people ask me about their hernia exploding, and that's not really something that happens, but the hernia can have intestines that get trapped in it, and that can cause some problems.
Okay.
Yeah.
So I know that we're obviously talking about the robot, but there are lots of ways to fix hernias. Is that right?
Sure. Hernias have been fixed for, over a century, really. And the very common way is to do an open traditional surgery where you just make an incision and cut down directly on top of the hernia to fix it. Then laparoscopy, as you know, came about in the 1980s, and we started using small keyhole incisions to do all different types of surgeries. And now we have an advanced form of laparoscopy, or an advanced form of minimally invasive surgery, which is the surgical robot, and we're going to be showing you that today. So, Dr. Bernier, you're also a robotic surgeon, so maybe you can talk a little bit about the robot for us.
Yeah, I'd be happy to do that. So the robot, as she mentioned, is an advanced type of minimally invasive surgery. When we use that term, minimally invasive surgery, it is to minimize the trauma to our patients from doing an operation. And there are a lot of great things that we can do with big incisions, but we know it's hard on patients and it makes their pain worse, their recovery is worse. In my field, if I make a huge incision, then their risk of hernia is higher, and then they need to go see Dr. Wheeler. So we use this to try to expand the types of things that we can do minimally invasively. So with laparoscopy, while you're still making those small incisions, we're somewhat limited in what we can do. I always tell people to think of the little trash grasper that people might see picking up trash on the side of the road, where there's a handle on the end, and then, or on your side, and then on the end is just a mouth that can open and close. That's the way our laparoscopic instruments are. And so they're great, and we've trained really hard to be able to do a lot with them, but the robot allows us to have more degrees of motion. They're wristed at the end so they can move, and it just allows us to do some of the things that previously could only be done open, minimally invasively, to again pass that benefit on to our patients so they have faster recoveries. For my surgery, so their bowels start working faster, their pain control is better, all of that just makes a better experience for our patients, which is, always our first goal. And the robot's gone through several iterations. This is the XI robot, which is the most recent one in their 4th generation technology. And with each version, they've gotten a little bit better. The instruments are a little bit smaller. The way the machine works is a little bit less cumbersome so that we can progress that technology through different types of operations. Again, bringing it to more and more patients so they can see that benefit.
Yeah, and at Valley we have 2 of this latest generation surgical robot, and we're very happy about that. And we have many, many robotic surgeons here. So robotic surgery started out with mostly pelvic operations in the early 2000s, and that was by like gynecologists who did hysterectomies, for example, or urologists who were working in the pelvis on like the prostate and the bladder. Very recently, though, it has expanded to hernia surgery, and we've seen a huge boom in growth of robotic surgery usage with hernia repairs. So we're going to show you a little bit about the robot today and talk about a little bit about how it can be used to do hernia repairs.
And one thing that I think is important, because oftentimes we as robotic surgeons get that question of, well, why do you use the robot? Is it just a fun toy? And we do enjoy using it for sure, but we do it because of the benefits. So specifically for hernias, what are the benefits that you see above laparoscopy in fixing a hernia repair or fixing a hernia robotically?
Oh, there's a number of things, but the most important thing is less pain. So our patients with robotic surgery have very quick return to work, very minimal use of narcotics often afterwards, and just less pain and a faster recovery. The other really great advantage is now the robot is very flexible for us, and we can do many types of hernia repairs with the robot, and we can be a lot more flexible in what we're doing, exactly how to fix it. And hernia repairs really depend on the type of hernia, how large it is, and where it is in the body. So you have to have a lot of tools together, and the robot helps us do that. To me, it's a more secure repair, and it's a lot more flexible than doing the open way. We also have a lower incidence of wound problems like wound infections with the robot.
So one question that we both probably get asked a lot is, what does that mean that you have a robot operating? You know, do I just type in fix the hernia and then I go
press a button
on my coffee break and some other magic happens? And that's not really the case, right? So we're still doing the operation, but we're controlling this machine. So it has 3 main components to it. The one we're standing in front of right now is the patient cart. So that means this is the part that actually is doing the physical work. We are there at the bedside at the beginning of the operation, putting in the instruments and the what are called ports, which are sort of the little plastic straws. Yeah, this is a good one.
We already have this docked here to demonstrate what it looks like for a patient. This is our lovely plastic patient friend here, and these are the trocars or the ports. Those mean the same thing. That would be going into small keyhole incisions in a standard patient.
We have an extra port.
And then we attach this patient cart to these trocars and insert the instruments through the trocars.
So we're there at the beginning putting those exactly where they need to be for each of our specific operations. So we put them in slightly different locations. And then we have a well-skilled assistant at the bedside then here, taking the instruments in and out, for example. So we take them out like this and then click them back in. And one of the great things is that the robot has memory, so whenever it has this green light flashing, they can put it just right back in, and it goes exactly where it was before, except a millimeter back, just to make sure that we're not hitting anything inadvertently. So that's what's going on in your abdomen. I asked when I stepped off screen a second, just so that you could see what this looks like. One of the things that's really cool about the robot is this fat black band right here that's called the remote center. So if you imagine this being connected to a person's hands and we're moving an instrument around, we could torque and move this and put a lot of tension or pressure on the abdominal wall. But the robot knows exactly where this remote center is. So anytime we're moving an instrument, it rotates around like this. So it's not torquing on the belly wall the same way that a laparoscopic instrument would be, which we think is a big part of why there's less pain, because this is fixed right at that spot in your belly, and then everything else kind of rotates around that point.
Yeah, pivoting around a stable point. Right. And you can see the camera is in here as well, and that translates to 3D imagery for us on the surgeon console, which we'll show you next. But the important point that Dr. Bernier was getting to is it's not a true robot. Robot means it acts on itself. You program it, it acts by itself. We are controlling it all the time. Yeah.
So that's the first main portion that's important to know about. And then we'll probably do this one last. And then this is the vision cart, or some people call it the energy cart. So this is what has all of the components. Our camera plugs in here. Our energy devices plug in here if we need to use cautery or any other kind of advanced energy devices. Those all go in here. And then this is usually sort of side by side with the other equipment that we need to fill the belly with carbon dioxide and whatnot. So that's that part. And then a main screen here. And one of the cool things about this, and I wonder if it'll let me do it now. Yeah, so if you're ever trying to teach someone or in proctoring situations, or if you're at an institution where there are residents, trainees, or just another surgeon who's trying to learn, if I draw something on here trying to say, oh no, I want you to get this piece of candy, she can see that, and then you can clear it out of the way. So it's just another way to communicate between the surgeon who's stuck over in their surgeon console.
So this is the third component, the surgeon console. So this is where we sit and control the instruments that are over on the patient, and we're going to show you that now. It has, again, 3D vision through here, and the instrument controls are here and here, and there's pedal controls for the camera, and then some of the energy devices like cautery that we have. So should we do demonstration?
Yeah, I think one of the first things that would be helpful is for you to sit and just show how your hand, before we show them this screen, just show how your hands go in there and the flexibility and mobility that you have with your wrists, because I think that's really important.
Great. So another good thing is we get to sit upright and we don't have to lean over.
A lot of surgeons with laparoscopy started developing worsening back problems and other things because you're trying to reach an area, and so you're sort of torquing and twisting, and it was a sort of unexpected byproduct of this big advancement in laparoscopy. So it does allow us to have a more neutral position for our own health and the longevity of our career, so we can keep helping people longer.
All right, so that's what it looks like for me, and then we can do the demonstration now. I have a couple things inside our fake abdomen over there that I'm going to try doing for you, okay? All right. You guys have video on inside the abdomen? Okay.
I think so.
So first, for reference, we have a penny there so you can see the size of our instruments. Penny's quite small. The instrument tips are quite small too. So that makes for good fine manipulation of the instruments. So I have a grasper here in my left hand, and I have a needle driver, or what we would use to suture, in my right hand. I've never done this before, but I'm going to try to unwrap candy. And you can see I can turn it over, I can pick it up, I can grab, little fine points on the candy.
And one of the things that she just did naturally without even bringing it up was that she also controlled the camera. So one of the things when we're doing laparoscopic surgery is our assistants, who are great, they hold the camera for us. Whereas with the robot, we can control all of the instruments. So she could immediately move the camera exactly where she wanted it to be to see her task at hand, move it in, move it out. That's all her doing that. So we can really hone in on what's important to the surgeon at any given time.
Anybody want a piece of candy? It looks like licorice, so be careful. Okay, and just to show you some of the manual dexterity here, this is a little game that we sometimes play with people that are training on the robot, moving the rings around this metal piece like this. So the good thing is I can flip my hand whatever which way I want. And again, moving the camera. I can switch hands. And you see my hand and my wristed features. You can see right here the wristed feature of that instrument. This translates to us being able to suture inside the abdomen, which is great for hernias. Now, I want to show you a little bit of a demonstration on what a hernia is. So if you imagine we're inside an abdomen here, you would have intestines all down here, And you would have the abdominal wall up here because we have blown you up with carbon dioxide. Greta, do you want to explain what that is?
Yeah, so we need to have space to work, and the abdomen is essentially just a big sack. And so when we put our trocars in, or when we put the first one in, then we inflate the belly with carbon dioxide so that we have working space. Basically, we blow everyone up like a big balloon so that we have space between the belly wall and the rest of the intestines on the inside. We use carbon dioxide for a couple of reasons. One, because it's not flammable, so we want to make sure, obviously, that it's nothing that could catch on fire. But it also diffuses rapidly into your tissues. So we try to get all of it out when we're done, but there's always little pockets of gas, as you can imagine, and so the more that we can get out and the faster that it diffuses away, the least discomfort people will have because of it.
Great, thanks. So for a hernia, imagine that this is material coming from the inside of the belly and going through this hole in the abdominal wall. It could be intestines or it could be fat. But one of the things we do robotically when we're repairing our hernia is we first take everything out of the hole. It's one of the more satisfying parts of my job. And there we are. And this would be all of your tissue, intestines, and whatnot back down into the belly where it belongs. And then I can look up at the hole with the robot and then repair this. So there you go. That's our robotic demonstration.
So one thing people often ask is about, do you use mesh? When do you use mesh? When don't you? I know it's a much more complicated question than probably the scope of this, but just what would your general response to that be for people who don't know about that, or maybe heard commercials on the on the TV about mesh is terrible and why? What's your response to that?
Yeah, mesh is a big discussion. Maybe we could do it in another webinar. But there are certain types of hernia that require mesh to fix them, and certain that don't. And so, for sure, I talk about mesh with every single one of my patients if they need it. And there's a lot of different materials to use. But it is a prosthetic implant, kind of like if you had a knee replaced or a screw in a bone or something like that. It stays inside you permanently, and it is one tool that we use to fix hernias. Again, the robot's great for using mesh because we can sew it in really nicely with the robot. Mm-hmm. Yeah.
And you brought this up a little bit earlier with respect to our different options of how to fix a hernia, and now you're talking about different options for mesh. I think one of the things we always stress is really individualizing our care to each of our patients. What one person needs isn't necessarily what somebody else is going to need, or what one surgeon feels the best doing may not be what another surgeon feels. And so every person that comes in, we just really try to evaluate you and your particular problem and then cater your care plan to that.
That's particularly true with hernias. There's a million ways to fix hernias. And it really depends on the patient and the surgeon. So it's really nice to have the flexibility of being able to do a lot of different stuff.
Yeah. So say I'm at home and I've had this bulge for a long time and I just watched this amazing webinar. But now what do I do?
So if you think that you have a hernia, if anything here is ringing true to you, there's a couple things you can do. You can either see your primary care provider, or you're welcome to call us at General and Surgical Specialists and make an appointment to check you out. So you can call the Main Valley Medical Center hospital number and ask for the general surgery clinic, or I can tell you the number. Get ready. 425-228-6076. And we'd be happy to see you, check you out, evaluate whether you need surgery or not. I would say, though, that hernias are a lot easier to fix when they're small than when you wait too long. So you can imagine fixing a hole this big is a lot easier than fixing a hole this big. So I would advise you to get in before your hernia gets too big.
And my understanding, too, is it's not necessarily just the ease of fixing it, but the risk of it coming back, right? The bigger they get, the higher your risk that it's going to come back. And so if you kind of head it off at the pass, then get a much more durable repair.
That's right. Yep, and much less complicated, less pain if we get it early on. So,
good.
We're planning on doing more of these Facebook Live webinars, so keep tuned in. The next one we're planning is for Dr. Bernier in March-ish. Do you want to talk about that?
Yeah, so we'll refresh some of these things about the robot just because it took us years to learn these things, so we don't expect everyone to know everything all at once. So we'll do a little refresher on that, but then I'll also talk about how I've adapted it into my practice of colon and rectal surgery. So the way that we do colon resections, in particular, in really complex cases where there's maybe a lot of inflammation from diverticulitis, which is a really common thing we see, or our cancer operations, and making sure that we're doing a good job of taking everything out that needs to come out. The way that this has helped colorectal surgeons has been really helpful. And in particular, we talked about briefly about the different generations of the robot, but this last generation, the majority of the updates that were made for it was with colorectal surgeons in mind, because unlike gynecologists or urologists who are just in the pelvis, or even when you're just focused at a hernia, we as colorectal surgeons are sort of fancy plumbers, right? But we have to get all those pieces of the pipe to fit back together. So if I'm taking out a section down below, I might have to work on a section up above, and so I have to be able to go all around the abdomen to get our operations done, and the XI has been really sort of revolutionary for us and our patients. So happy to talk to you about that.
Incidentally, they did that for colon surgery, but it's what started hernia surgery boom with the robot. So it's been great for both of us.
Yeah,
I think.
absolutely.
So, all right, well, tune in next time, you guys. Thanks so much for coming in.
Yeah, are there any? We're happy to answer questions as they come in. If anything comes up after this, or you're thinking about it in a couple days, or you're watching this not live, we're always happy to answer any questions that you have at any time.
So let's ask a couple of questions from the staff here. So what makes a person more likely to get a hernia? Is it genetic? Is it my activities? Do I have risk factors that I can, make sure that I'm not doing ahead of time so I don't have to have a hernia?
Yeah, so anything that increases the pressure inside the abdomen is going to put you at risk for hernias. So sometimes that is hard work, so physical labor, a lot of heavy lifting, weightlifting, and that kind of thing. Sometimes it's medical conditions like obesity, pregnancy, liver disease where you have a lot of fluid in your abdomen, someone who has to strain to urinate, coughing, anything like that where you would have stress in your abdomen. I think, of course, it's good to maintain a healthy weight and just be on the watch and on the lookout for hernia signs and come in early. Some of it's things that you can't help, but some of it are things that you can.
What if I had a parent who's had a hernia? So if I have, my dad had a hernia when he was in his 20s and I'm in my 20s perhaps, should I be worried about the same thing happening to me if I have a similar lifestyle?
Not necessarily. We don't have any certain genetic link with hernias, although I do hear about them running in families, and we're not 100% sure why that happens. But you don't have to do anything more than be cautious of symptoms and be aware of your own body if you have somebody in your family that has a hernia.
Okay.
Good questions. Thanks.
Sure.
Thank you.
All right. Thanks,
All right.
guys.
Thanks, everybody. Have a good weekend.
Okay. Woohoo!